Well, welcome everyone to our renal grand rounds. I'm Penelope Capicinu, an associate professor here in the nephrology division at Northwestern. And it is with great pleasure that I introduce our guest speaker for renal grand rounds today, Dr. Rizk. Dr. Rizk is a professor of medicine in the Division of Nephrology at University of Alabama at Birmingham. Her clinical and research interests revolve around glomerular diseases with a particular focus in IgA nephropathy. She has served as a PI on many clinical trials, and she is a member of several multidisciplinary translational research projects examining biomarkers in IgA nephropathy. Her research efforts have led to many peer-reviewed publications in prestigious medical journals, including the New England Journal of Medicine. Dr. Rizk is the Director of Clinical Trials Research in the Division of Nephrology at University of Alabama since 2015. And she's going to talk today about the pathogenesis of IgA nephropathy and future treatment. So I will stop here and we'll have Dr. Rizk take the lead.
Thank you so much, Penelope. Thank you for the kind introduction, and thank you for inviting me today to join you. A lot of familiar faces, so it's great to see everybody. So as Penelope mentioned, I hope that by the end of the lecture today, you will have a better understanding of the pathogenesis of IgA nephropathy, but also have hope for the future of IgA nephropathy in that there will be a treatment and maybe sometime in the future a cure for this disease. These are my disclosures. So I'm going to start with a case presentation. This is representative of cases that I see. This is an individual, 24-year-old Caucasian male who presented for evaluation of hypertension, microscopic hematuria, and proteinuria that was discovered when he applied for life insurance. And he was told he had 2+ protein on his dipstick. His family history was negative for kidney disease. And when he came to clinic, his blood pressure was still elevated at 154/96. His BMI was 28.5. His serum creatinine was 1.5. Urine analysis did confirm the presence of proteinuria and hematuria, about 3 to 10 red blood cells per high power field. And when we did the 24-hour urine collection, we did confirm 1.5 grams of protein. We sent him for a renal ultrasound that confirmed the presence of 2 kidneys, normal in size and contour, and just mildly increased echogenicity. And so we set him up for a kidney biopsy, and the diagnosis came back as IgA nephropathy. Again, nothing unusual about this case presentation. I often bring people back after a biopsy, and these are the questions that I get faced with. So what is IgA nephropathy? Why me? What is causing my disease? What's going to happen to my kidneys? Will I need to be on dialysis? And how are you going to treat me? And I hope that in the next 45 minutes or so, I'll be able to address all of these questions and maybe some more at the end during the Q&A session. So what is IgA nephropathy? It is the most frequent primary glomerulonephritis in the United States and the world. The true prevalence of the disease is really unknown, and that's for several reasons. One, the screening for IgA nephropathy requires routine urine analyses, and as you well know, in the United States, for example, past the pediatric age group, we rarely get urine analyses without a cause for it. With the exception of women during their OB care or GYN care. And in those cases, we often see women being told they have recurrent UTIs or blood in the urine that may be ascribed to their menstrual cycles. So a lot of missed opportunities to diagnose the disease. The threshold to perform biopsies varies around the world. So we, for example, in the United States, don't biopsy people that have isolated hematuria, but in other parts of the world, they do, like Japan. And autopsy series, but also biopsies done at the time of allograft implantation in people that obviously have been screened for kidney disease prior to kidney donation. revealed the presence of IgA deposits in about 5 to 15% of cases, sometimes with evidence of nephritis, mesangial proliferation, and other findings, and sometimes just isolated IgA deposits. So there is a subset of patients that have subclinical disease. So with all these reasons, the true prevalence is unknown. It's probably more than we think it is. We do know that the annual incidence based on kidney biopsy series in the United States is estimated at 1 in 100,000 people. The peak incidence is in the second to third decade of life. There's a male preponderance in the United States with a male to female ratio of 2 to 3 to 1, whereas in East Asia, that ratio is closer 1 to 1. And again, there may be true biologic differences between the disease in East Asia and the United States, and it may also in part be related to things I just mentioned, screening and performing biopsies. We don't know. It's a frequent cause of end-stage kidney disease, and there are rarely familial cases. So there is, again, as far as presentation is concerned, there was nothing unusual epidemiologically about the patient that I just presented. So what do we look for when we do kidney biopsies? We look for what Jean Berger, a French pathologist, described in 1968, this new entity that at the time he dubbed Berger's disease, which now we know as IgA nephropathy. And it is characterized, as you all know, by this immunofluorescence pattern that shows IgA mesangial deposits that have to be either dominant or co-dominant with other immunoglobulins. It is often accompanied with C3 deposition in about 90% of cases, often with IgG in about up to 50% of cases, and I'll come back to that point because it's important, and sometimes IgM. If we look under light microscopy and stain with PAS stain, you will see mesangial expansion, but also proliferation as shown here. And then there are elements of chronicity we look for, such as segmental sclerosis or global sclerosis and tubulointerstitial fibrosis as well. On EM, what we see are electron-dense deposits, again, in the mesangial area, occasionally in the paramesangial area as well. So if we do routine immunofluorescence, as I mentioned, we see only C3 deposition on top of the IgA or IgG. However, if we do special stains for other complement proteins, we find a slew of deposition of C4d, C3a, so on and so forth, indicating that this disease, at least at the tissue level, is characterized by activation of the alternative complement cascade, the lectin pathway, and the terminal complement cascade as well. And that becomes relevant when we talk about treatment. So what do we know about the IgA nephropathy pathogenesis? It is now well accepted that it is a multi-hit disease, and that was, this graph comes from a publication that was generated here at UAB before my time with the IgA group that suggested that it involves multiple hits. The first one being an increased production of what we call galactose deficient IgA1, and I'll describe that in a minute. That's then recognized as an autoantigen, and therefore the body will form unique anti-glycan antibodies against it. And the combination of these autoantibodies and autoantigen form pathogenic IgA1 containing circulating immune complexes that deposit in the kidney, specifically in the mesangial area, and ultimately lead to glomerular injury if we start seeing proliferation, extracellular matrix production, and again, under the influence of multiple cytokines and growth factors. So what do we know about the HIT1 or this galactose deficient IgA1? Several important observations early on in the disease description came to light, and the first one was the fact that in the mesangium we see primarily IgA1 deposition, and that this IgA1 that's deposited is typically a polymeric immunoglobulin A. So just to remind you, we have two isoforms of immunoglobulin A in humans, IgA1 and IgA2, and the difference between the two is really this part of the immunoglobulin that's called the hinge region. So in IgA2, there's almost no hinge region, it's very short. And in IgA1, we have this long hinge region that is characterized by the presence of O glycans. So these are specific amino acids like serine and threonine that have an oxygen moiety to which sugars get attached. And so that alerted investigators that there must be something about this IgA1 that is special that's making it lead to the IgA nephropathy. And in fact, what we find is if we look at these 9 serine threonine locations, 6 of them typically are involved in glycosylation. And in patients that have IgA nephropathy, they have galactose deficiency, meaning less galactose sugar attached to these oxygen moieties. So normally what you see is you will have first an N-acetyl galactosamine depicted here in the squares that gets attached to the oxygen moiety, and then you add, or the body adds to it, galactose or sialic acid or both. And in patients that have IgA nephropathy, they have mostly these glycoforms that are lacking the galactose depicted here in the black circles. So a higher amount of galactose deficient IgA1. And this ultimately was also confirmed in the serum in that patients that have the disease have higher levels of galactose deficient IgA1 in the circulation, and that in the circulating immune complexes, there is mostly a polymeric galactose deficient IgA1. So again, completing this whole understanding of this first hit. I will point out that the polymeric IgA1 is typically seen at the mucosal level. So it's also unusual to see high levels of polymeric IgA1 in the circulation, but that is peculiar of IgA nephropathy. And I'll come back to that and hopefully offer some explanation. So when we here at UAB looked at a large cohort of patients, they were mostly Caucasians that had IgA nephropathy and compared them to healthy controls, what we found is that patients have by far a higher level of galactose deficient IgA1 in the circulation. Most of them are above the 90th percentile when compared to controls. And if we took that test alone to see what was its predictive value, we found an 88.5% positive predictive value and a 78.5% negative predictive value if we measured galactose deficient IgA1 in patients versus controls. So not a perfect test, but a pretty good screening test. It's important to note that the galactose deficient IgA1 elevation alone does not trigger the disease. We do need autoantibodies to proceed to have immune complexes and ultimately IgA nephropathy. And that has been shown in family members, for example, of patients with IgA nephropathy who have a high galactose deficient IgA1, not to the same level as the disease cohort, but higher than healthy patients and may never develop the disease after 15 to 20 years of follow-up. So let's look at the autoantibody. Again, as I mentioned, the aberrantly or galactose deficient IgA1 in the blood of IgAN patient is mostly found in circulating immune complexes, and it is bound to either an IgG moiety or another IgA. These autoantibodies seem to recognize the N-acetyl galactosamine that's now uncovered because it doesn't have a galactose covering it. And the IgG autoantibodies result from a somatic mutation that then allows these autoantibodies to recognize this new epitope and form immune complexes. So again, looking at this autoantibody, we were curious to see whether the IgG autoantibody or the IgA autoantibody played a bigger role in the disease pathogenesis. So in conjunction with collaborators from Japan, we looked at a cohort of 135 IgAN patients. We took 76 disease controls that had kidney disease but not IgA nephropathy, biopsy proven, and 106 healthy volunteers. And this may be a little busy, but let's start here with the healthy volunteers. So on the x-axis is the galactose deficient IgA1. It's a logarithmic transformation, but these are Gd-IgA1 levels. And on the y-axis, we have the IgG autoantibody in this graph and the IgA autoantibody in this graph. And as expected, in healthy volunteers, there are very low levels of both, and there's really no correlation between the two. As we move on to CKD, again, low levels of both and no significant correlation between the two. And when we look at the IgAN cohort, you can see that they have higher level of Gd-IgA1, but importantly, they have a very good correlation between their autoantibody IgG levels and the galactose deficient IgA1. And we found no correlation between the Gd-IgA1 and IgA, which suggested that perhaps the IgG autoantibody is the most important one. And in fact, when we divide, again, in the blue are the IgAN patients, and the red are the CKD patients. I'm sorry, in this graph, it's the healthy volunteers. You see that patients that have IgA nephropathy have sometimes both the IgG and IgA autoantibody elevated, but by far and away, about 90% of them are to the right of this dotted line here, meaning they have a high level of the IgG autoantibody predominantly. So this suggested to us that the IgG autoantibody is the predominant autoantibody to look for in the disease pathogenesis. And so we went back and looked at our pathology and wondered, why then do we not detect immunoglobulin G in all kidney biopsies? And so normally, as I mentioned, in classic Berger disease, in the initial original description of the disease, they found IgA, they found C3, but they also found IgG or described IgG in all their biopsies, but that was a select patient population. And IgA had to be either co-dominant, just like in this picture, or dominant immunoglobulin by definition to make the diagnosis. However, in other series that came subsequent to the disease description, up to 50% of patients will have an IgG negative disease by routine immunofluorescence. So to answer that question, we turned to some remnant kidney biopsies. We had remnant tissue, and we did a series of experiments in the lab. We were able to extract the immunoglobulin G from the immune deposits in those kidneys or remnant tissue of those kidneys. And we tested this immunoglobulin G for binding specificity, meaning does it bind to the galactose deficient IgA1? So we took two separate sets of tissue in what we call the positive RIF, that's patients that have positive IgG by routine immunofluorescence, that's what your pathologist reports, and another set of tissue that had IgA but was negative for IgG by routine immunofluorescence. And in summary, what we found is that even in cases that were negative by routine immunofluorescence, we were able to extract immunoglobulin G, although in smaller amounts than in cases where the routine immunofluorescence was positive. And when we tested this immunoglobulin G for specificity, looking, does it bind to the galactose deficient IgA1, we found that these deposits and this IgG is enriched for autoantibodies that are specific for galactose deficient IgA1. Again, negative cases have less IgG and positive cases more IgG, but they both bind to galactose deficient IgA1 and are enriched for that. When we looked at confocal microscopy, which is a fancy microscope that for the fellows will look for overlap of IgA and IgG, we can see that in the positive routine immunofluorescence and the negative routine immunofluorescence, there was almost confocal presence, co-localization of IgA and IgG, suggesting that those are probably co-localized and we think bound together to form these immune complexes that deposit. Again, maybe in smaller amounts, but they were present. So that kind of confirmed the disease pathogenesis, this multi-hit hypothesis. And to put this whole story together, what we think happened, and again, we, the royal we in the scientific community looking at IgA nephropathy, is that the B cells are initially primed at the mucosal surface. And that could be because of exposure to mucosal infections, to changes in the microbiome, which I don't have time to go into today. But regardless, maybe the diet, the cells are primed and they become IgA antibody secreting cells. So this galactose deficient IgA1 that's polymeric on the mucosal surface somehow gets translocated into the circulation. And that step is not quite understood. We don't know why these cells then start dumping this galactose deficient IgA1 into the circulation. we think there might be a mishoming where these cells go to the bone marrow and release the galactose deficient IgA1 into the circulation. That is then recognized in the right individual that has the right genetic background or genetic predisposition. It is recognized as an autoantigen against which the body starts forming autoantibodies. Again, IgA autoantibodies and IgG autoantibodies, but by far and away, we think the IgG plays a much bigger role, forming immune complexes that deposit in the mesangium and cause renal injury. So we explained to the patient how the disease develops to the best of our understanding in 2022. And his next question was, what is going to happen to me and what is going to happen to my kidney function? Well, this is information about mortality, which I personally don't share with my patients, but I keep in the back of my mind when I'm treating them, is that, you know, IgA nephropathy for the longest was thought of as a benign disease. And in fact, a lot of patients tell me that, you know, I was told I had blood in the urine, that I'll have no problems for many, many years. But there have been multiple studies now that show that the diagnosis of IgA nephropathy increases mortality risk and shortens life expectancy by about 6 to 10 years. Importantly, this increased mortality risk seems to be mediated by the development of end-stage kidney disease. And so about 20 to 50% of patients will progress to end-stage kidney disease within 20 years from the time of the biopsy diagnosis. And with that comes the increased mortality risk. Importantly, when we say that the disease peaks in the second and third decade of life, you're talking about people that are still pretty young, in their 40s, 50s, 60s at the most. So it is something we need to pay close attention to. So who are these patients that are at increased risk of disease progression and hence need to be treated probably more aggressively? And the first and most important probably clinical biomarker that we have that's going to herald disease progression is proteinuria. And this is a classic paper from Heather Reich in Toronto that was published now close to 15 years ago, that showed very nicely, based on registry data they had and very long follow-up data up to 15 years, that at the time of diagnosis, if patients have, they were divided into different levels of proteinuria. And what you can see is that patients that have high degrees of proteinuria, more than 3 grams per day, do pretty poorly in terms of renal survival. And that risk becomes better as the proteinuria goes down. And there seems to be an inflection point at the 1 gram per day mark, where people that have less than 1 gram a day of proteinuria do much, much better than the other cohorts. Having said that, there's also data from this cohort and others that suggest that perhaps 1 gram is pretty generous, and in the future we may be even more aggressive, targeting a proteinuria level of less than 0.5 gram per day, again, to mitigate the development of end-stage kidney disease. So keep that in mind when we talk about treatment, because that then helped us risk stratify patients that are going to be enrolled in clinical trials to test new therapeutic interventions. The other important clinical piece of information that helps us determine the patient's prognosis is a pathologic scoring system that was developed during a large consensus conference in Oxford, England, where pathologists and clinicians came together and they pulled data from multiple large cohorts, international cohorts, I should say, and that led to the development of what we know as the MEST-C score. So the M in MEST stands for mesangial hypercellularity, E for endocapillary hypercellularity, S segmental sclerosis, T is for the interstitial fibrosis and tubular atrophy, and C for the presence or absence of crescents. And I've mentioned here the different scores, and you can look at those later on. You'll get a copy of the slides. However, suffice it to say that the higher the score, the more severe the prognosis, the higher the likelihood of disease progression. The M1, S1, and T1 and 2 scores are associated with poor renal outcomes, which makes sense. These are markers of chronicity, the S and the T scores. The E1 lesions and the C lesions may predict response to treatment, specifically immunosuppressive treatment. And people that have C2 lesions are going to do poor even when treated aggressively with immunosuppressive drugs, for the most part. That doesn't mean we shouldn't treat them, but just again, when you see somebody that has a C2 lesion, just keep in mind that they probably need close follow-up. Importantly, these histologic findings predicted outcomes independent of proteinuria, blood pressure, and eGFR. So they added to the clinical markers that we have. So with both of these pieces of information, Sean Barber from, again, Canada, with an international group of collaborators, came up with the International Risk Prediction Tool, which predicts a 50% decline in eGFR or the development of end-stage kidney disease for up to 7 years post-biopsy, post-diagnosis. The variables that are used to calculate that risk are readily available variables. So the MEST score, note here that there's no score for crescents because at the time they did not have a large enough population with crescents to be able to validate the score. So that might change with time and they may update that risk prediction tool. So I would say if you see a fair number of crescents, certainly a C1 or C2 lesions, you have to be concerned about that patient regardless of the risk prediction tool. They took into account age, eGFR, systolic blood pressure, diastolic blood pressure, the use of RAS blockade at the time of the biopsy, and immunosuppressants. They developed this risk prediction tool to be validated with or without the race as a variable. So if you don't have the race factor available to you, you don't need to enter it. If you do, you can enter it, and doesn't change, honestly, a whole lot the risk of progression. And it's available for free at this web link here. So in 2021, the KDIGO guidelines were updated with this new information. And the guidelines recommend that if we diagnose an IgA dominant glomerulonephritis, the first step is to exclude secondary causes. Again, I don't have time to go into these today, maybe some other time when you invite me to come back, but we can talk about the IgA vasculitis or Henoch-Schönlein purpura. They're talking about IgA dominant post-infectious GN, so on and so forth. So you want to exclude these cases or secondary to inflammatory bowel disease and so on and so forth. If you have a primary IgAN case, then you score the kidney biopsy using the MESC score, and hopefully your pathologist is giving you those scores. Then you risk stratify the patient using the international prediction tool. You enroll the patient in a disease registry if you have one. We locally keep a database, for example, a sort of disease registry for our site. And then you start optimized supportive care. So what is an optimized supportive care? Well, it includes ACE and ARB, irrespective of whether the patient has high blood pressure. If they're proteinuric, they need to be on ACE and ARB. The target blood pressure is very aggressive, less than 120/75. Remember, most of these patients are young and healthy and should be able to tolerate low blood pressures. And you target a very low degree of proteinuria, as I mentioned. You can use statin therapy if they're hyperlipidemic. They have to be on low sodium diet, advised about smoking cessation, avoiding nephrotoxins, and targeting healthy weight and exercise, just like we do for all our other CKD patients. So if patients, despite the supportive care, remain proteinuric, and you give this optimized supportive care up to 3 months at least, then they need to be considered for enrollment in a clinical trial. And notice that they went to clinical trial first before considering steroid use, and I will share with you the data for that. If their GFR is too advanced, you may want to consider just maximal supportive care and really nothing else, because the benefit of immunosuppressive therapies may not outweigh the risk. If the GFR is preserved and they don't want to be enrolled in a clinical trial, then you could consider a trial of steroids with consideration for the risk, that particular patient's risk for steroid use. So why did steroids fall out of favor? I would mention that steroids were the only treatment, or one of the main treatments we gave, except for fish oil and Cytoxan if people had aggressive crescentic disease. But pretty much a lot of patients went on steroids several years back. And that fell out of favor with the publication of the Stop IgAN trial and the testing trial. And I'm going to briefly remind you of those. So the Stop IgAN was published in the New England Journal of Medicine in 2015. And what they did is they took patients that were at high risk of IgA nephropathy, that were still at high risk of progression, and randomized them to get either supportive care. They really all get supportive care for about 6 months, and then they were randomized to get steroids if their eGFR was above 60, or steroid with Cytoxan and Imuran when their eGFR was between 30 and 59. And remember, so this is the trial was published in 2015, but this was the standard of care at the time they were enrolling. And importantly, after the run-in period with aggressive supportive care, about 34% of patients had dropped their proteinuria below 0.75 gram per gram, which was the entry criteria for the trial. Again, which led to these new KDIGO guidelines saying that if we aggressively optimize supportive care, we may not need to be very aggressive with immunosuppressive treatment. So keep that in mind when you're treating your patients in clinic. And what they found is that the steroids were associated with a high rate of clinical remission in terms of proteinuria, but that was at the expense of more adverse events, including even a death in the steroid arm. And when they followed these patients further up to 8 years out, and published this data in 2020, they found that the improvement in proteinuria with steroids did not really translate into kidney function preservation. So that made people pause and think before prescribing systemic steroids as a first-line agent or as a knee-jerk reflex when they saw IgAN patients. In parallel with that, the testing trial had started in Asia, and the testing trial was looking at the role of methylprednisolone versus placebo, again after 6 months of a run-in period during which supportive care was optimized. And that trial had to be stopped early because of serious adverse events in the treatment arm. They were mostly related to infectious complications, but in that group, in that population, methylprednisolone did seem to provide renal benefit in terms of eGFR decline and ESRD, and reduced proteinuria. This trial, again, as I mentioned, started in Asia, and most patients that were being enrolled at the time were of Chinese descent. So with that, the Data Safety Monitoring Board then suggested they continue the trial, but reduce the prednisone dose. So they reduced it from 0.6 to 0.8 milligram per kilogram per day down to 0.4, which translates to about 30 to 40 milligram of prednisone roughly. Not a small dose by any stretch, but a lower dose. And they wean these patients, again, by 4 milligram daily per month. They also recommended that they give them PJP prophylaxis for the first 12 weeks, and they recommended raising the lower limit of eGFR to 30, whereas in the parent study, that lower limit was at 20. And with that, the testing low dose trial, which is the continuation of the testing trial, the results were shared in the ASN late breaking trials in 2021. And they were very encouraging in that the primary outcome, which was a composite of kidney failure, 40% decrease in eGFR or death due to kidney disease, was significantly reduced in the treatment arm. At a mean follow-up of 4.2 years, the hazard ratio of the primary outcome was 0.53, and this was statistically very significant. If we look at kidney failure alone, the hazard ratio was 0.59. Again, a very significant p-value. And by that time, they had enrolled patients not only from China, but also from Australia, Canada, very few US participants, but regardless, they did not see any geographic distribution of this benefit. And the incidence of serious adverse event that was seen was mostly in the full dose steroid therapy, so the first part of the study, and less so in the low dose trial. So again, a much better safety profile and potential benefit. So in the future, we may again bring back steroids and we may use them, but in a subset of patients, again, at high risk, and weighing the pros and the cons of using steroid in your particular patient. Do they have diabetes? Are they obese? Do they have bone problems? So on and so forth. So what else do we have in terms of treatment? Well, two pivotal events happened that allowed us to test new therapies in IgA nephropathy. One was the better understanding of the disease pathogenesis, but the second was the Kidney Health Initiative, which in 2016 was born out of a public-private partnership between the American Society of Nephrology and the FDA. And that project or partnership initiated the project to identify endpoints that could be used as a basis for assessing efficacy of IgAN nephropathy. Again, remember, this is a disease that progresses over 20 years, so we can't do studies that are that long. We had to find surrogate markers. And the evidence from all the available data at the time showed that there was a strong and consistent relationship between proteinuria and loss of kidney function. And if we were able to treat proteinuria successfully, that translated into treatment effects on the composite of doubling serum creatinine, end-stage kidney disease, and death, so heart outcomes. So with that, we opened Pandora's box. And as you can see, this is the same slide I showed you earlier with the pathogenesis understanding. And you can see that all these drugs here highlighted in different colors are targeting IgA nephropathy at multiple levels, be it at the mucosal surface, B-cell therapies that prevent the formation of the galactose-deficient IgA1 and the autoantibody, IgA1 proteases that will disrupt the circulating immune complexes, complement inhibitors that prevent renal injury and perhaps also prevent the activity of the circulating immune complexes, the Sglt2 inhibitors that's on everybody's mind, and also endothelin inhibitors. So I'm only going to be able to highlight a few of those trials, but just keep in mind that all these are going on and the treatment of IgA will change in the next 5 years drastically. So how about local steroids? The NefIgArd trial, and I'm only showing the phase 3 study, tested the benefit of Nefecon in the treatment of IgA nephropathy. So Nefecon is an oral targeted release formulation of budesonide, a type of steroid, and it is encapsulated in a special capsule that dissolves at the level of the ileum, where we have the highest density of Peyer's patches, and we think this is where this is the mucosal surface where this galactose-deficient IgA1 is produced, or where there is increased production of galactose-deficient IgA1. They included high-risk patients that had biopsy-proven IgA, preserved EGFR, and persistent proteinuria despite maximally tolerated RAS blockade, and gave them Nefecon 60 milligram per day versus placebo for 9 months. And in November of 2020, they released their top-line primary endpoint results that showed a 31% reduction in proteinuria in the 16 milligram arm of treatment versus 5% in the placebo arm, which means a 27% reduction at 9 months. So significant reduction in proteinuria. We're still awaiting the EGFR results to come back, but that hopefully will translate into EGFR preservation. And I should say that this is the first drug that has had conditional approval by the FDA based on these results. How about B-cell therapy? The most advanced program is the VIS-649, which is initially was sponsored by Vistera and now by Otsuka that bought Vistera. So hence the name VIS-649. This is a humanized immunoglobulin G2 monoclonal antibody that will bind and block APRIL, a key factor in the production of aberrantly glycosylated IgA1. So this is the proliferation inducing ligand that leads to proliferation and maturation of the B cells. Same or similar inclusion criteria, persistent proteinuria, a good EGFR of over 45 in this case. And the primary outcome is going to be the safety assessment at 12 months and the efficacy on proteinuria. VIS-649 is an IV infusion, and it's being tested at multiple dosing levels. So there are 4 arms, 3 with different doses and 1 placebo. And the phase 2 study has completed enrollment. The preliminary results are encouraging enough that they have embarked on a phase 3 trial, during which this drug will be administered now subcutaneously. So hopefully a little easier for patient administration. How about endothelin inhibitors? So the PROTECT trial tested the efficacy and safety of sparsentan, and sparsentan is a dual-acting angiotensin receptor blocker and endothelin receptor antagonist. The active angiotensin receptor blocker in that drug is irbesartan, and the active control arm receives irbesartan alone. Again, as you can see, similar inclusion criteria, more than a gram of proteinuria, GFR more than 30, looking at the primary outcome, which is a change in the 24-hour protein to creatinine ratio. And secondary outcome would be the eGFR results at year 1 and year 2. The study completed enrollment, and here again, in August of 2021, the top-line results were released, an impressive reduction of about 50%, 49.8 to be specific, in proteinuria from baseline to week 36. Again, hopefully this will translate into eGFR preservation. We don't know yet, the jury is still out, but very encouraging results. How about Sglt2 inhibitors? Of course, you've heard about them all over the place. The DAPA-CKD study enrolled patients that had proteinuric kidney disease, not diabetic kidney disease, and they had a large cohort of IgAN patients included, 270 patients. I will point out that this was a relatively sicker than expected population. The mean age was 52, which is a little bit old for IgA nephropathy. eGFR was about 44. Their UACR was about 900 milligram per gram, so nothing surprising here. But interestingly, about 17.5% of their population was diabetic, and about 3% had a history of congestive heart failure, which again is unusual for your typical IgA patient. But despite these limitations, DAPA reduced the primary composite endpoint, which is a 50% decline in eGFR, end-stage kidney disease, or death from kidney disease or cardiovascular cause, by a whopping 71%. So pretty remarkable. And again, the separation between the two arms starts fairly early at about 8 months. But it left questions unanswered. For example, the placebo group had quite a bit of primary endpoints, which was more than what we would expect from the bread and butter IgA population. Again, as I mentioned, it was a sicker group of folks. We don't know if they were optimized on ACE and ARB. They only had to be on a RAS blocker for 4 weeks. And we don't know if we can safely use it concomitantly with immunosuppressive drugs in the future with the risk of mycotic genitourinary infections and so on and so forth. Having said that, EMPA kidney may give us more answers as they have a bigger cohort of IgAN patients enrolled. So these results are eagerly awaited. How about the complement system? I showed you that there is evidence certainly on biopsies of complement activation, but there's also biochemical, genetic, and clinical evidence that highlights the pivotal role of the complement system in the progression of IgA nephropathy. And in particular, the alternative pathway and the lectin pathway seem to be activated along with the terminal pathway. So with that, and with the advent of specific pathway inhibitors, no surprise, those again proceeded to clinical trials testing their efficacy. And everything that I've added to this diagram of the complement cascades here in light blue are drugs that are being tested in clinical trials at various phases. So I'm only going to mention a couple, the LNP023 and the OMS721, simply because these are a little bit ahead of the curve in terms of phases of trials, but many more to come as well. So this is the Novartis trial for iptacopan, which is also known as LNP023. This is a phase 2 trial, and to remind you, iptacopan is an oral factor B inhibitor that inhibits the alternative complement cascade. And during the phase 2 trial, what they showed is that there was a significant dose response effect of iptacopan when compared to placebo on proteinuria. So you can see these are increasing doses of iptacopan. The most benefit was seen with the 200 milligram BID dosing, and it was fairly well tolerated. And so with that, they have now proceeded to a phase 3 trial, the APPLAUSE trial, that is ongoing and enrolling all around the world. How about inhibiting the lectin pathway? So OMS721 is, or narsoplimab, is a fully humanized monoclonal antibody that binds to MASP2 and inhibits the lectin pathway. This was also studied in a phase 2 study. Same kind of story in patients that had persistent proteinuria and preserved eGFR. And what they found was at 12 weeks, there was really no difference between placebo and narsoplimab. But when they extended the treatment to 18 weeks and beyond, what they found is that the narsoplimab group had a significant reduction, more than 50% reduction in their proteinuria. And following them to week 104, they all had stable eGFR as well. So with that data, they proceeded again with a phase 3 study that is currently actively enrolling. So what happened to our patients? I got the biopsy result back, and he had an M1, E0, S1, T2, and C0 lesion. So this is, again, the MES score based on the Oxford classification, reminding you that S1 and T2 are markers of chronicity, so not a good sign. And he had mesangial expansion and hypercellularity as well. So that did not look good, but when I plugged his information into the risk prediction tool, I was even more alarmed because according to the risk prediction tool, he had a 42% risk of 50% decline in eGFR or progression to end-stage kidney disease within 5 years. That's pretty alarming for a 24-year-old. So with that, we aggressively controlled his blood pressure. We gave him an angiotensin receptor blocker and titrated it up. And he came back 4 months later with a blood pressure of 124/73, but had persistent proteinuria at 1.1 gram per day. So I enrolled him in a clinical trial. And if you invite me back, I'll let you know what happened to him. The story is to be continued. I don't know yet. So in summary, hopefully I convinced you that IgA nephropathy, or reminded you, is the most common primary GN in the world. Its pathogenesis is compatible with an autoimmune process. There are clinical and pathologic biomarkers that predict the risk of progression, and that the treatment landscape is rapidly changing. And it is extremely important that we aggressively treat these patients, but also refer them for enrollment in clinical trials when their prognosis is not very good. So what does the future hold? I think we need to be more aggressive in identifying patients and diagnosing them, because now we have treatment for them. We need better risk stratification with novel biomarkers, be it the galactose deficient IgA1, the autoantibody, or other biomarkers, complement biomarkers. The jury is still out. We need strategies to select the best therapy for a particular patient. Will we treat differently at different stages of the disease? Should we use these drugs in the future sequentially? Should we use them concomitantly? We don't know. We need better assessment of treatment response. Now we have the clinical biomarkers, again, proteinuria and creatinine, which are fairly crude, and we don't repeat biopsies that often, and most patients would probably not want to repeat biopsies very often. How about children with IgA nephropathy? They've been excluded from every trial at this point in time, but that landscape is also changing. And how about IgA vasculitis with nephritis, or what we used to call Henoch-Schönlein purpura? We think it's on the same spectrum of disease, but really it behaves fairly differently. And will these treatments expand and be used in IgA vasculitis? We don't know. So with that, I thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Rizk, for really a fantastic talk with really exciting updates on IgA nephropathy. So I will start with a posted question from Dr. Cullen, who is asking, why do circulating immune complexes vector into the mesangium rather than the peripheral cap wall?
Great question. We don't know for sure. There is some data that they bind to specific receptors on the mesangium, but I think the story is not understood quite yet. We don't have all the information, and why the same immune complexes trigger IgA nephropathy in one patient, IgA vasculitis in another, is also a big question that remains unanswered. So great question.
One question that I have is that obviously, I mean, from GWAS studies as well, we now realize that there are certain genetic traits, for example, affecting the glycation process. Plus there is this heterogeneity in terms of pathogenesis of IgA. So with all these clinical trials now happening, how do you envision that the roadmap for precision medicine in IgA nephropathy will unfold? How basically, do you envision that in the next 5-10 years, things, will change around and we will be able to better treat patients and offer the new treatments?
That's a great question. So we do know there's for sure genetic predisposition. We also know that the prevalence of the disease, again, with the caveat of the prevalence assessment that I mentioned, but the prevalence is certainly different in different parts of the world, highest in Asia, then in Europe, and very rare in African Americans. It's probably one of the rare diseases that we hardly see in African Americans. So there is a genetic predisposition, and some of these GWAS studies did highlight some of the genes related to the multi-hit hypothesis. There's also presumably environmental factors. So some of the GWAS studies also suggested that the helmintic variability and exposure to different pathogens in the environment may play a role in the trigger. There are data on the variability of the microbiome that we haven't elucidated completely. So to your point, in the future, what I see this going, at some point in time, maybe we'll have a genetic background on everybody, but I think that's going to be further down the line, past the 5 to 10 year mark, in my opinion. But I think we're going to be able to look at different additional biomarkers beyond just the biopsy and the proteinuria and the hypertension. So we might be looking at, again, galactose deficient IgA1, the autoantibody level, how much circulating immune complexes do they have and what's their size, or how much complement activation do they have, and is that the predominant reason for their aggressive disease. So with that, we'll be able to tease out these variabilities and treat them differently. To your second point, there's no question that there's also, so even current trials have shown that there is differential response in different racial groups. So for example, I mentioned how the low testing trial seemed to show, at least in, although in Caucasians, we're seeing that maybe the benefit of the steroid doesn't outweigh the risk. In the Asian population, that seems to be a little different. They have pathologically more aggressive proliferative lesions. They have crescents more often than we see. So they might be different there as well. CellCept, for example, has been tried and shown not to be beneficial in Caucasians. In Asia, they show that they see some benefit, some reduction in proteinuria, again, on a background of a low dose of steroids. So it's hard to tease out the CellCept benefit. But just to say that there are differential responses in different racial and ethnic groups. So for those of you located in parts of the country where you see a more diverse population, colleagues in Toronto, for example, see a large Asian population, and even immigrants in Toronto seem to have a more aggressive disease than Caucasian Canadians. So we need to look at all that, hopefully with more specific biomarkers.
Definitely, that sounds great. So we have more questions. The next question is from Dr. Shika Wadwani. Fabulous talk, Dan, and she's thanking you for all the things that you have done to advance the field. So she has several questions, but she's curious to know whether you would consider an Sglt2 inhibitor after RAS blockade prior to a clinical trial, Nefecon, or systemic steroids.
That's a great question, the $1 million question. So I would say yes and no at this point in time. So it depends on the patient population. So for me, the Sglt2 inhibitors at this point in time are not really immunomodulators, and I consider them as an extension of RAS blockade. So if I see somebody that has had the disease for a long time, where I think most of the proteinuria is really chronicity and less so an immunologically active disease, I may recommend an Sglt2 inhibitor and wait and see what happens. And really, you get the benefit of an Sglt2 inhibitor fairly quickly within a few months. So you can always enroll them in a trial afterwards or give them an immunosuppressive drug afterwards. But if I see a young patient that has an incident disease that seems to have very aggressive disease, lots of hematuria, I may go straight to a clinical trial before I even put them on an Sglt2 inhibitor. That may change once we see the AMPA kidney results. And it also might change based on what the patient says, because I can tell you the Sglt2 inhibitors story is spreading like wildfire among not only physicians, but also patients. I've had several come through and say, what is this diabetic drug that I may be able to get? So sometimes, they want to go on an Sglt2 inhibitor. And I would say if that's the case, then just do it, get it done, and then, consider them still for a trial afterwards. But I saw today, for example, an 18-year-old with 3 grams of protein, a very aggressive looking biopsy. I went straight to a clinical trial. I mean, he's already maxed out on his RAS blockade. And I said, we don't have time to fool around. And, we'll see. But that's what I do for the time being.
Sure. The next question by Dr. Jean, I think that we have touched a little bit. You may want to add what is known about patient ethnicity in IgA nephropathy progression and treatment response.
Yeah, so I think there is definitely a gradation of disease. The disease is much more prevalent in East Asia, as I mentioned. So there's definitely a genetic predisposition to disease development, but also prognosis. The disease seems to be more aggressive. They have more proliferative lesions. They often report seeing crescents. And it's less aggressive in Caucasians. And like I said, rare in African Americans, almost unheard of in true Africa, in Central Africa. And the US, in the African American population, we see it, and it may not be as rare as we think, but that may be also to some extent genetic admixture. So yes, there is definitely a difference in risk, but also in risk of progression with the disease being more aggressive in Asia.
Next question is by Dr. Ronald Cullen, who is asking that COVID-19 begins with upper respiratory tract mucosal inflammation. So have you seen any IgA deposits in patients who have kidney involvement in the setting of COVID-19 infection?
So we have seen, like everybody else, I think, case reports of people that twofold, that developed IgA after exposure to, COVID infection. Not in alarming grades to where we would have kind of a solid correlation, because we've seen all sorts of primary glomerular lesions develop also post-COVID infection, not just IgA. Interestingly, in people that have IgA that got either COVID or COVID vaccine, we've seen gross hematuria. So they would often report having gross hematuria for a few days, whether that's related to the mucosal exposure or just this inflammatory response and perhaps complement activation that leads to, activation of the disease. We don't know. But nothing that, at least in the short run, had seemed to be causing significant problems. So we still vaccinated our patients and alerted them that they may have gross hematuria in rare cases. And if they do, and it persists past 2 to 3 days, to come in for repeat labs to see what's going on.
Great, and I think that answers also, the question by Dr. Wadwani, who is also, asking if you are adjusting RAS blockade in these patients with COVID vaccine or, with COVID disease. So,
no.
Great. So I guess the last question will be that we typically do not biopsy patients with isolated hematuria, since other diagnoses are there, like Alport's or thin basement membrane. And there are no effective treatments. So given proteinuria predicts worse outcome, would you continue to just observe these patients and think about biopsy if proteinuria worsens, Or is there a role for measuring serum IgA, IgG levels to see whether non-proteinuric patients should be biopsied?
That's a great question. So in this day and age, I would still say we have to stick to observation and wait, because there is a subset of patients that have isolated hematuria. They may have IgA nephropathy, but they do very well long-term for many, many years, 15, 20, 30 years. So there is a subset of IgAN patients that really never develop progressive disease and do well. Whether that's related to different levels of the biomarkers that I mentioned, meaning they have them, but maybe they're not as high as in patients that develop progressive disease, we don't know yet. The Gd-IgA1 and IgG autoantibody are not available commercially at this point in time, and measuring total IgA or total IgG is not helpful at all. So for now, I would certainly I don't see the need to biopsy them. I have several of those patients in my clinic that I haven't biopsied. I think in the future, if we are able to better risk stratify people with more disease-specific biomarkers, not just proteinuria, I would say, yes, I would like to biopsy these people because I would want to establish their diagnosis earlier and treat them earlier. The other thing I would say is we really need to be careful about the message we give to patients. I've had several people say, I was told I had blood in the urine, but I was told it was a benign condition, no problem. And they come back 10, 15 years later and they've evidently developed proteinuria at some point in time and had progressive disease that nobody kind of picked up on because the patient quits following up. If you tell them it's a benign disease, they're not going to keep checking on it. So I always tell them this is a disease. It's not normal to have blood in the urine. It's most likely IgA nephropathy or whatever else I think is going on. I don't see the need to biopsy you, but you absolutely need to follow up on a yearly basis. And if something changes, that conversation might change as well. So I don't let them out of my sight, essentially.
Excellent, and it makes great sense. So I do not see any other question on the chat box. Thank you so much for staying, even beyond. It's 1:05. With that, I will close our renal grant rounds here. Thank you for the wonderful talk, and thank you everyone for attending.
Thank you so much for having me, and thank you for sticking around past the hour. So have a great day.